Okay, welcome back, everyone. I hope you had a good break. We are going to finish the last little section of today with Dr. Naomi Jones, who I had the pleasure of working with at Croydon. It is my first time reg, and she looked after me a lot. But she's now at King's NICU, and she's going to talk to you about managing a new role in outpatient. Thank you.
Cool, thank you, Emma, and well done everyone for making it to the end of the day. So I'll try not to be too long so you guys can get out into the sunshine. So I'm going to talk about managing a new role in outpatients, which is something that came up on the Mentimeter as being an anxiety, and yeah, it's something that was an anxiety for me, but I've been a reg for 2 and a bit years now, and now feel so much better about it. So I'll go through why it can be a really good thing. So yeah, going to talk about the opportunities, the types of clinic, some common presentations, how to run it with some tips and tricks, a bit about admin, and some helpful resources that I found along the way. So these are the 3 key tips I have for clinic. So I'd say prepare and plan ahead. That certainly for me significantly has reduced my anxieties about clinic, and I'll sort of talk about why as we go through. It is okay not to have all the answers. Again, this is something that a senior reg said to me just before my first ever rapid access clinic, and it's the best piece of advice I've ever been given about clinics, because I kind of expected that, like, I'd get there and the families would turn up and they'd want me to have all the magic answers, and actually that's not the case. And it's okay to ask, and it's okay to call them back, which I'll talk about in a bit more detail in a minute. And also embrace the opportunities. Clinic has so much opportunity for learning clinically and non-clinically as well, so really embrace that. And for example, if you think about a lot of our exams, a lot of what we think about is like chronic condition management. And also, particularly as SHOs, you work acutely so much. And then, say it's like an asthma or epilepsy, for example, you'll stabilize them acutely, and then it will say follow up in clinic. And now's your chance to learn what happens in that clinic, what changes to prevent that child coming in acutely so often. Clinic is also a significant proportion of consultant life. Unless you end up doing PICU or PEM, it is a large proportion of your life for basically every other specialty. So now's the time to start learning about it. It's a really different approach, which I think can be really good sometimes. You're in that room, even if it's a busy clinic, you're in that room with just that child and that family. And that's really great. You're not going to get bleeped off to a blue call, and that's really nice. It's also, you're quite independent. You sort of figure out your own little pattern. The way you do clinic, you figure that out yourself, and you're very independent with that, and I love that. And I know that's something that's come up a bit, in the Mentimeter, what we're excited about for becoming registrars, and this is an opportunity to do just that. It's an opportunity to teach others. You quite often get medical students in clinic, so that's a great opportunity to use to teach them. It's also a great opportunity for you to get work-based placed assessments, and is often a better time than acutely, because you've got a consultant with you, or you're discussing things in more detail, and you can also get those discussion of correspondences that you need to get as a registrar. So there are varying types of clinic. In general peds, you're going to have a mixture of new referrals and follow-ups, I guess same in most specialties. But from general peds, most of the new referrals will either be routine or rapid access, follow-ups from previous clinic, previous inpatients, and also sometimes local follow-ups from a tertiary hospital. And then you'll also end up doing neonatal, specialty and community clinics. And the way you do clinics is going to vary depending on the type of clinic and on the hospital. So sometimes rapid access clinic is reg-led, sometimes it's not. Sometimes you'll be doing a clinic with a consultant, so you'll take a couple of patients from their list. Sometimes you'll have your own list. Sometimes, in particular, if it's a specialty clinic, you'll end up sat in the clinic like a medical student, which can be actually really interesting, and you can ask some really targeted questions, and it can be a really good opportunity to use for that. So I thought about some common GP referrals for general peds and the kind of things that you kind of end up getting in clinic. And this is main things I've come up with. And And yeah, if anyone thinks of anything else, then by all means put it in the chat. But things to kind of, you know, think about and to maybe look up and that sort of thing, particularly constipation. A lot of constipation comes to general paediatric clinics. There are a few hospitals that have specialist constipation clinics, but not many. So it's worth getting to know how to manage that well. But lots of other things as well. And as we mentioned at the start, you guys have fairly recently done your exams, so you're in a great position to be treating this stuff. From other specialties, most neonatal clinics and NICU follow-ups, whether that's neurodevelopmental follow-ups or looking at babies with chronic lung disease and so on. But you also get the occasional jaundice and heart murmur follow-ups, and I imagine a lot of you guys have done SHO prolonged jaundice clinics already. Peds follow-ups, common things are asthma, epilepsy and endocrine, and in community, mostly developmental delay, but also lots of looked after children clinics, EHCP, which is education and healthcare plans, medical assessments, ADHD, autism and neurodisability as well. So as I said, one of my main key tips is to prepare and plan ahead for clinics. So there are ways to do this and different things that you need to know in advance. So in induction, think about asking what the types, timings and locations of clinics are. Most places, in fact everywhere, should have a children's outpatient, but sometimes some clinics don't take place there. So it's just worth finding that out. Rapid access clinics, for example, in some places take place just off A&E. So it's worth just finding that out. Also ask about admin stuff. So how a clinic note's done, for example, it's often done differently than inpatient stuff. So you might be electronic for inpatient, but written for clinic and vice versa. Or same thing about dictation. Where do you find dictaphones? What's the dictation software? Have you got a login? All that stuff. How do you check letters? How to organise investigation from clinic varies in trust by trust, and how to organise outpatient prescriptions or urgent medication requests from GPs. Most trusts discourage too many outpatient prescriptions from clinic because of cost, but sometimes you think that child needs that medication there and then, and you don't want them waiting to see by the time your letter has come through and got to the GP, you're several weeks down the line, and so you need them to have something sooner than that. So how do you go about doing that? It's also worth asking about late arrivals and was not brought policy. As Joe mentioned earlier, recurrent was not brought can be a safeguarding concern, but you know, everyone has the occasional time where they forget things. So what is the policy to do with those things in your trust? And then how to prepare a few days before on the day. And this is something that I have found really helpful going along. So if you've got a day down for clinic or a week down for clinic, then what you want to know is what type of clinic is it? What type of clinic are you going to go to? And is it your own list? So as I mentioned, you might have your own rapid access clinic. You might have your own list with a consultant running their own list in another room, or you might be taking patients from the consultant's clinic. So it's worth finding those things out. And as part of that, find out who your supervisor is. Every clinic that you do should have a consultant's name overseeing it, even if they're not physically in the building with you. So what you want to know is who that is and where they're going to be and how do you get hold of them. So the ideal situation is that they're in the outpatients with you, perhaps in a different room. And if they're doing their own clinic, then you know, are they going to want to see every patient just to say hello, which some consultants I've worked with like to do? Are they happy for you to interrupt them in the middle of their consultation? Would they rather you waited for gaps between patients or even to the end of the list? And sometimes, particularly with rapid access clinics, for example, the responsible consultant might be the attending ward or A&E consultant. So if you need something from them urgently, how do you get hold of them? It's also worth asking them what they want to do about letters. I would suggest that you dictate and check your letter and then send it to them for review. And you can discuss patients at the same time. But as you get more confident, they may be happy for you to send your letters out without them looking at it. Every consultant is slightly different. And then the thing that I've probably found the most helpful is a couple of days before, if you can, particularly if it's your own clinic, to read the referral or the previous clinic letters and the results. Because then that way you can look up or ask about anything you're not sure of, so you're not going to be surprised. If you don't quite have the chance to do that a few days before, then at least do it at the start of the day before you see the clinic, and particularly before you see the children, so that you know kind of where you're going, what you're doing. It's often particularly helpful with follow-ups to say to the consultant, what did you have in mind about this child at a follow-up? What exactly is it that you're reviewing? What questions do you want me to ask? And then you know kind of how to structure that consultation. So also practically on the day, arrive in outpatient before clinic starts. You do not need to go to handover on a clinic day because it's not relevant to you. So just head straight to outpatients. When you get there, check that you have a room, and check that your IT works, because that doesn't always happen, and check that you've got the equipment that you need, particularly things like head circumference tape measures for neonatal clinics are really important. Check in with the consultant again, particularly if you haven't already, just to make sure they're happy with everything. And then, as we've been saying, use the nurses as your resource. Get to know your outpatient staff. Get to know how they do heights, weights, blood pressures and urines. They should be doing really heights and weights on every patient, but blood pressures and urines you might have to ask specifically for. And how are you going to know that your patient's arrived? Are they going to knock on your door? Are they going to ring you? Is there a computer system? It's all variable. It's also worth giving them a heads up if you think you might need a chaperone. I had this once with a child with precocious puberty, and I knew that her appointment was sort of middle of the clinic, so it meant that I could say to the nurses at the start of the day, I'm going to need a chaperone for this one. And it was really helpful because it meant that they could plan their workload and plan their breaks, knowing that they were definitely going to be needed at that particular time. Time management is an important thing to think about in clinic, but realistically, particularly as you start, you may well find that you end up running late. And if that happens, then apologise to every family, obviously. And it also helps if you update the outpatient staff as well. And then that way the receptionists and the nurses can be apologising and updating families who are waiting to see you in the waiting room. It just helps to manage expectations and minimise stress. So that's kind of preparing, and then you get into your consultation. And it's slightly different to an acute consultation in that it's often a bit more focused. So if it's a new patient, obviously you're going to want to take your paediatric history and be quite thorough. But if it's a follow-up, you really don't need to do that. You need to figure out what has changed since the last appointment, how are things going. The other thing I find helpful to do is to ask myself, what question is the referrer asking? And then also, what question are the parent or the child asking? Because they're often different things. Qualities of referral letters vary. I've had some 5-word ones in the past. Sometimes you get whole long letters. It's really variable. But sometimes actually all the GP might be asking is for you to rule out something really serious. And they might have done loads of things. They might have got the bloods, they might have taken loads of information, and actually there's nothing else for you to do except for saying it's fine. And that's okay. But sometimes it's worth just thinking about that when you read the letter. And it's often worth asking the parent and the child that too. Because this is an acute problem, they usually will have had time to think about it, time to Google it. So they may be coming to you with a slightly different agenda than what they have in A&E. And that's okay. But it's worth being explicit and finding out what that is so that you know what you're dealing with. As always, talk to older children alone. Also, always remember to plot height and weight and head circumference for neonates. Even though this is a non-acute thing, you still need to remember your red flags and safety netting, particularly for problems that can have acute presentations. And then, like we've always said, you're not alone in this. Ask for help and ask urgently if urgent. Even if someone has said, oh, you know, run everything past me at the end of the day. If you've got an acutely unwell child or an acute safeguarding concern that means you don't want that family to leave the hospital, then you need to change that plan and ask for help urgently. And then I guess moving on to my next main tip about clinic, it is okay to not have all the answers, and this particularly relates to making your plans. Clinic is an amazing opportunity for you to learn how to make plans, but you don't have to make the final plan, and particularly when you start off. So the advice I would say is to make a provisional plan if you can, but if you're not sure, be honest with families about that. Families have always been fine about that with me. I've never had an issue at all. And say to them that you're going to talk to the consultant who's responsible for the clinic and let them know later. And I guess as you get more confident, you can phrase this in slightly different ways. I have in the past said to a family, there's something not quite right here, but I'm not sure what it is. So I'm going to talk to the consultant and call you back. I've left it that open in the past, but sometimes I've said, okay, here's a plan. I'll call the consultant and call you back to confirm this afternoon. Sometimes I've said, here's a plan. I'll speak to the consultant, and if anything changes, I'll call you. But if it doesn't, then I won't, and just follow this plan. And then sometimes I've said, you know, I talk about every patient with the consultant just out of courtesy, just so that you know, it's, you get more and more confident in different things as you go, and that's fine. What I would say though is remember to check the family's contact number, because sometimes you say this and there's no phone number on the system, or the phone number that we do have on the system is incorrect. So just make sure that you do have the right one before you offer to call them. Again, something that Ria mentioned this morning was about dictation. So I would strongly encourage you to dictate your clinic letters. And this is going to be something that feels really alien. And that's fine. And it gradually gets a bit less alien, but it's still weird. But it is what it is. Every human being hates the way their voice sounds when they hear it back. It's just part of life. Some trusts won't actually let you type. So even if your trust now lets you type, you might find in the future that a trust doesn't let you type, and then you'll be really out of practice. Also, I've had lots of consultants say to me when I started, and I completely agree with them now, that dictation ends up being quicker than typing the more practice you get. So you might be slower to start with, but now is the time that you're investing in your long-term future, not just for now. But it's okay. You don't need to put too much pressure on it and too much pressure on yourself. Dictations are not the finished article. It's not what's going to go out to families. So you might find that things, you get it back and it looks a bit weird and slightly out of sync, but that's the whole point. You change it and you learn and you develop, and that's absolutely fine. A few tips I would say is try to dictate as you go along, or at least soon afterwards, because you do forget stuff. It's just who we are. Try and keep some good contemporaneous notes in clinic, in case when it's transcribed, there's a bit that's unclear that you have to go back and double check. Speak slowly and clearly in a quiet room when you're doing it. Remember to use patient identifiers at the start of each dictation. And the other thing I find really helpful is to email admin staff to look out for your dictation. In most jobs, you won't have a specific registrar admin person, and therefore either what happens is your dictations go into a random pile and get allocated to no one and never get dealt with, or they go to the responsible consultant who then gets sent all the letters for checking, and they can't check them because they didn't see the patient you did. So if you email the consultant secretary and say, I've just seen X, Y, and Z patient, please could you look out for their dictation? And then the other thing that's helpful, if you ask them to let you know when it's ready, it means that you get a bit of a prompt to remember to check your letters. When you're writing letters, try and keep a good structure, keep clear sections, and particularly in longer letters, for example, complex patients like in the community, consider using subheadings. The minimum subheadings for any letter, I would say, would be issues, auxology, like your height, weight, etc., and a plan. And you can put in other ones along the way if you want to. Think about how you communicate your requests for the GP. If there are lots of things to be done or it's complicated, you can put a problem list and then your plan and then have the body of the letter, because GPs have a lot of letters to read. So it's okay to put it at the start, and then you are more reassured they're more likely to read it. Also think about how you phrase what you'd like the GP to do, because it's all about kind of, professional politeness and all that. Also think about who to CC the letter to. Always send it to the family, but are there any other professionals involved that need to know? When you're writing referral letters, which you don't always do, but sometimes you do not need to reinvent the wheel. So you have to write a separate letter, but you could say, dear colleague, a problem list, and remember to include the problem that you're referring at the top of that list, and then have a couple of sentences about what that problem is and why you would like that specialty to see this child. And then you can say, please find enclosed the clinic letter for more information. And then you can ask the admin team to send those two things off together. And that just helps to avoid you duplicating yourself. Also, always remember to check your letters promptly. You need to find a way to be able to do that. We are all supposed to have admin time within our rotas, but obviously that's often times that we end up taking leave. So use little opportunities. Occasionally you have a window where things aren't too busy, or otherwise you need to raise it with the consultant team if you're not getting the admin time to check the letters that you need to do. Also, when you see a child, part of your plan always needs to include follow-up. And when you're making that plan, think about what the purpose of the follow-up is going to be. What exactly do you want checking at the next appointment? And that helps you to decide how quickly you want that child to be seen as well. And this, again, is going to be something that you learn along the way. And that's fine. And so initially, you're not going to know what the follow-up plan is going to be until you've spoken to the consultant. But you always have to do your outcome forms. It's really, really important for NHS waiting lists and funding. And if you don't do it, you will be hounded by the outpatient admin staff. It's okay to wait until you've spoken to a consultant to do your outcome forms, but always remember to do them. Sometimes they're on paper, sometimes they're online. And it's basically where you tick either discharge or see again, basically. And that's where you also tick when you want them seen again, and then the follow-ups can be arranged from there. It's usually how it works. You need to chase up any investigations or referrals that you make. So find a system that works for you. An Excel spreadsheet is often helpful. So some hospitals that I've worked in, the online system actually gives you a little announcement in your inbox when things are back. I found that really helpful, but that's not the case everywhere. So think about what you're going to do about that. And of course, we all move on. So remember to hand things over that are pending. And I would say hand that over to the responsible consultant from that clinic. Just a couple of minutes about telephone and video consultations, because obviously with COVID that's happening now. I've not done many videos, but I've done a few phone consultations, and they present opportunities and challenges both for us as professionals and for families. A few tips I would say is clarify who is present, particularly on the phone. You're often on speakerphone when you're doing a phone consultation, and so the person who's answered is usually not the only person who's there, and you want to know that, so ask at the beginning. You're obviously going to have fewer non-verbal cues, so be clear in your communication and be creative in the way you ask questions. Technically, when you're using video software, often it's helpful to do a split screen, so you might have the referral letter or the system up on one side and then the video up on the other side. Think about what might happen if you lose signal. So it's helpful at the start of the appointment to say, if we lose signal, I'm going to ring you back. Please, can you confirm your phone number? Because usually people often take their children out of school for video appointment and sit there doing it in the car on 4G, and the 4G signal is often not enough to do a video appointment with. Also think about time management. You don't have a waiting room in the same way. So if you are running late, it's harder to let people know. Often with the video software stuff, there is a little waiting room. You can put a bit of a message in, but not always. So just think a bit about that. And also, if you think that this child needs examination, then ask the consultant about how the best way to go about arranging that is going to be. So just before we finish, I wanted to just share some resources I found really helpful. This book on the left-hand side was one of the most helpful things that a consultant has suggested to me. It's got examples of, it's all outpatient based, and it's got examples of the GP letter or the health visitor letter or whatever, and then differentials, how to approach the consultation and how to manage the diagnosis. It's really helpful. There are also 15-minute consultations and archives on lots of things. There'll be guidelines locally, nationally. Paediatric Foam, if you haven't found it, which I'm sure you will probably have, has lots of stuff. And there's also patient information sheets, particularly from Gosh or Birmingham Children's, but there are loads from all over the shop that are helpful to use. And then this is a little library of web resources I found helpful along the way. You will build your own library up as you go, and as people recommend things to you. I'd particularly recommend the eric.org.uk website for constipation, and I'd suggest that acutely as well, because it's really good for advice about how to use a disimpaction regime. But yeah, I'd strongly suggest that one. And then there are lots of others as well that I found helpful along the way. So just to summarize, these are my 3 key tips for clinic. Prepare and plan ahead. It is okay not to have all the answers, and embrace the opportunities. So thanks very much. Does anyone have any questions? And then I put my email address at the bottom as well, if people have anything they'd like to email me about.
Wonderful. Great. Thank you. Now, thank you so much for the lovely talk, Naomi. It was like fully packed with all little tips, which is I also find it very useful too. I actually wanted to show you, can I share one screen? Because this is one document that I wanted to really, I found it very useful as when I first became a registrar. I don't know whether you guys have seen this or not. It's from Birmingham Children's, and then it has got very comprehensive management and referral guidelines for pediatric outpatient conditions. And it really has got quite a good range of stuff you can see. And it has a very quick guideline that you can actually look to use. So I will also distribute this in our email later on as well. Okay, thank you so much for your talk, Naomi.